Hello everyone, myself Dr. Ruchit Patel, Associate Professor at UNMICRC Institute of Cardiology and Research Center, Ahmedabad, in the Department of Cvts. As a part of Masterclass series, today I would like to discuss about Dextro Transposition of great arteries and arterial switch operation from its embryology to long-term outcomes. This operating steps, we look for anatomical correction, the arterial switch operation, which restore the left ventricle to the systemic circulation. The goals of the operation is to transect and switch the both great vessels. So, LV is connected to the aorta and right ventricle to the pulmonary artery to provide the true anatomical correction. Then the coronary artery buttons are harvested and are implanted into the neo-aortic root at the original native pulmonary artery, the root. Then reconstruct the neo-pulmonary root with pericardium, relocate, if needed, relocate the pulmonary artery anterior to the aorta. That is the counter maneuver. Most cases we will do it. And look for any associated VSD closure or LVOT. This section if needed needs to address along with that. So we are providing the LV as the systemic ventricle from the outset to avoid the late cardiac function that we have observed during with the atrial switch operation like sunning or mustard, which leads to later right ventricle failure, arrhythmia, or any complication, Baker's leak or stenosis. For cannulation techniques, median sternotomy, after median sternotomy, setting up for bypass, we do median sternotomy, then harvest the pericardium if needed, treat with the glycerol for that, neo-pericardial, neo-pulmonary artery reconstruction. Aortic cannulation is done as distally as possible, usually at the base of the innominate artery origin, and to get the adequate length of the ascending aorta. And bicoil cannulation is preferred in the most cases. Cardiopulmonary bypass is established with moderate hypothermia, usually around 30 degrees Celsius. DHC is required in cases of we need to address arch lesions, coarctation, or maybe interrupted use. Ductus is, after going on pump, ductus is divided usually, and branch pulmonaries are embolized as distally as possible till the hilum to allow the tension free anastomosis and bring it anterior to the aorta. Cardiopulmonary is given, usually blood is diluted with preferred as the cross clamp time is usually around more than 60 minutes to most of the cases. And we look after at the time of cardiopulmonary, we look for the weight, or we also look for the planning the coronary button harvesting where there will be transecting the aorta and look for the coronary artery buttons and intramural segment or have anomalies, abnormal origin of circumflex or RC there. Great vessel transection. Aorta usually transected just above the sinotubular genus, and pulmonary artery is divided at the level of just proximal to its bifurcation. Transection level is not there. This is not the rule. We have to look usually chosen as per the coronary patterns, and just main purpose is to provide the tension-free anastomosis after the operation, and also look for the side mismatch, particularly in cases of VSD cases when the rich pulmonary hypertension will have with pulmonary artery is larger than the aorta. Like county maneuver, bifurcated pulmonary artery is brought anterior to the aorta before the neo-pulmonary anastomosis is completed. What is the purpose is to provide a tension-free anastomosis to proximal neo-aortic proximal neo-pulmonary route to the pulmonary bifurcation. So in original jetting operation, we used to do there was no like counter maneuver was used. So there was interposition graft was required to connect from the proximal to distal pulmonary artery anastomosis. So with leg counter we can directly connect it to the root of pulmonary artery without using the interposition graft. This is most commonly preferred approach in most of the cases until there is anatomical variation that prohibits the leg counter maneuver in cases. Particularly those are in cases where there is DURE with crossing in anomaly where side by side great vessels are there. We we need to put the anastomosis under tension that will lead to future stenosis in the outflow tract of the pulmonary artery. Supravalvular aortic stenosis, particularly the LP origin can be there, or some coronary patterns like in left coronary is looping around the pulmonary artery, then it's like abdominal will lead to put compression or kinking of the left coronary artery. So in these cases, we need to avoid eccentric yanning. Now, the coronary artery transport is the most critical step for this arterial sleeve operation because how and most early complication or life-changing complication for this surgery are the coronary artery transfer. Here, the coronary during coronary harvesting, the STR exercise generous buttons with taking around the surrounding aortic sinus wall, leaving the ring of around 1 to 2 mm for the proximal pulmonary artery construction. And this generous button is required along with mobilization of the proximal part of the coronaries to avoid any osteal distortion. And then particular attention is paid to the proximal course of each coronary artery, particularly when there is intramural segment is there. Here, we need to look for the intramural course of coronary arteries, and we need to unroofing of the ostium to get it mobilized without distortion of the ostia. Here we can also divide it, take as a single button, or you can divide in the commissure level between the ostium. Now these buttons are translocated and reimplanted into the original pulmonary root, that is will be neo-aortic root after the surgery, with care to avoid kinking, stretching and torsion. These are the most common factors leads to coronary ischemia after the surgery. So with the advance in the surgery, as in the right side of the figure, we can see we can use trapdoor technique. Here we provide provide tension-free or kinking of or torsion of the proximal coronary segments. While making coronary incisions or implanting the coronary arteries, we usually place medial based trapdoors, or just put a medial based incision in the lowermost part of the coronary harvesting implantation areas. So there will be to avoid the torsion in the proximal part of the coronaries. As seen in the right side of the first figure is there for IC, and right second part is showing for the left coronary arteries. And then the donor side from the native aortic root is reconstructed with the peripheral patch, might have treated or non-treated with neutral anterior. This is the most important critical factor for this surgical procedure, and it needs to be addressed with meticulous care. Now, after this coronary button, we are going to complete the vascular anastomosis for the great vessels. Neo-aortic anastomosis is done for the distal aorta to the neo-aortic root. With here we have harvested the implanted the coronary buttons. Need size mismatch needs to address at this level to avoid the supravalvular aortic stenosis. Neopulmonary anastomosis is completed with a native aortic root connected to the distal pulmonary artery nearest bifurcation after doing the lectotomy. And as seen any size mismatch or spiraling or beveling may be required in case of the size mismatch in there when VSD and large coronary arteries are there. VSD, if the associated lesion in VSD is closed, maybe through the tricuspid valve, or maybe in the outflow tract is there, some aortic septum can be through the great vessels, or in myofical can be in the through ventricular. My discrete LV outflow tract option can be addressed with direct resection until if we are planning for two ventricular artery switch operation, and there is moderate to severe stenosis there, we need to that will permit the arterial switch operation. So we'll, in cases of intraventricular baffling is present with outflow tract VSD is there, we can do a restyle operation as shown in the finger. Here we intraventricular baffle to having the left ventricle blood to aorta, and right ventricle is connected to the pulmonary artery with the interposition graft or conduit as in cases of restyle, particularly right in DRV. there is severe stenosis there and VSD is not notable, another option is REB procedure, row and floor ventricle, or maybe Nikaido can be done. In Nikaido, we do aortic translocation, where which aorta is resected along with coronaries and will position posteriorly, direct position posteriorly over the left ventricle posteriorly. So there is direct alignment of left ventricle to the aorta, and then pulmonary artery is brought anteriorly to the right ventricle through outflow tract that can be connected directly or maybe with the interposition graft or the pinch convinced. Another new technique that we have now started doing is the half truncal switch operation in cases of there is mild to moderate stenosis in which both great vessels are not totally rotated, but 180-degree rotation is done to bring the aorta posteriorly and aorta and pulmonary artery anteriorly. Special scenarios in tossing anomaly is a form of double outlet right ventricle when there is subpulmonary VSD in there with side-by-side great vessels. So here with subpulmonary VSD, but pulmonary blood flow is effectively transposition through the VSD from left ventricle through VSD into the pulmonary artery. Usually left ventricle outflow tract or maybe associated arch obstruction or coarctation is usually present in such scenarios and more common than simple return. So their repair requires arterial switch operation with intraventricular baffling of left ventricle to the aorta through by VSD closure in such a way, and associated coarctation or arch hyperplasia and rest of may require circulatory arrest for that. That when we started before the coronary transfer. So arch may be repaired before coronary transfer in such cases. In experienced centers and with large volume centers, the outcomes are still excellent, but they have still higher morbidity or early outcomes or morbidity or mortality rather than high risk such than the simple DA. And here the Lecomte manual may lead to active stretching of the pulmonary vessel, particularly the branch pulmonary artery, and LPA may be like to get compressed by ascending aorta or the proximal aorta. So it may be required to augment the branch PA with pericardial patch. Late presenting TGA with interventricular septum. Beyond 3 to 4 weeks of age, when the child presents late, usually the LV fails to sustain its systemic pressure because of it is ejecting into the low pressure pulmonary circulation. So after arterial switch, it is likely to get to support the systemic circulation after arterial switch operation. So in such cases, when child has a regressed LV or LV mass is not enough, we can do two-stage rapid two-stage arterial switch operation near the pulmonary artery bending is done, or maybe required associated shunt to increase the LV after load or preload and rebuild the LV mass. So after the PA bending, we do a serial echocardiography in the ICU to monitor the progress of the LV mass index and the volume and posterior wall thickness. And we can also consider the shape of banana. If irregularly it is from banana shape to if LV pressure are getting back, geometry changes from banana to rounding shape. Once we find that LV mass or geometry is adequate, there will be LV mass index is more than 30 mg per meter square, or maybe volume is more than 35 ml per meter square, or the posterior thickness is getting more than 3.5, that is borderline the accepted criteria for arterial switch operation. Then we can consider for the second stage arterial switch operation. The rapid two-stage operation is the priority nowadays, whereas to compress these days to that rapid stage, it means we are doing around within days or weeks, maybe 7 to 10 days after PA bending, we are doing the arterial switch operation as described by Jonas, outcomes described by Jonas and Lecomte, which they have taken the LV mass index more than 35 gram per meter square. And first original rapid two-stage description was given by Jonas et al. Now post-operative and long-term care. early post-operative changes. For myocardial protection, how can I avoid the low cardiac output or early recovery for the left ventricle? Usually cord blood or crystalline cardioplasma we deliver in the integrally with rheumatoid root, and timely repeating of the dosage is required to avoid the stunning of myocardium post-operatively or avoid the dysfunction. If there is extensive suture line is there with coronary mobilization, we need to do meticulous dearing is required, particularly in the coronary arteries, because after releasing the cross clamp, there can be air trapping in the coronaries that leads to getting the rhythm delay or maybe arrhythmia or ST changes in the cases of early post-operative failure to wean from the bypass. Then modify the ultrafiltration because there is a long bypass time is there. We can consider modified ultrafiltration usually is preferred to reduce the total body water and inflammatory mediator in the circulation, particularly in the neonates when there can be systemic inflammatory response syndrome in the neonate, leading to leaky capillaries in such cases. Temporal epicardial pacing wires are usually placed in cases where pacing is required or maybe blocked to waste necrotory involved. And in post-operative gradual weaning from bypass with assessment as per the assessing the ventricular function in neonatal transport, esophageal echo and coronary flow, we can directly visualize during the remodeling period. After clamp removal, we can see any regional wall abnormalities or abnormal coloring is there in the dusty myocardium is seen over the coronary region. Early post-operative in ICU, we should maintain the hemodynamics properly to maintain coronary perfusion pressure adequately and avoid tachycardia or hypertension or excessive afterload. Inotropic support, usually low dose adrenaline or medicinal support is required and needs to tailor as per the ventricular function and rhythm. Close monitoring for signs of any coronary event or like there will be ST changes, arrhythmias, regional wall motion, abnormality may be there, or in case there is rising lactate level in the results of any coronary coronary transfer is not properly done and lead to coronary event, or maybe ventricular fibrillation or arrhythmia can be there. Ventilation post-operative is to optimize the pulmonary vasculature in cases of TG or D or with VSD and minimize the myocardial oxygen demand. Judicious fluid balance with maybe telling how many cases require or dialysis to maintain or modify ultrafiltration in the neonates to maintain the fluid balance, and particularly child which are styles are undernourished, early nutrition should be started and structural development care should be given to neonatal brain to consider the better neurodevelopment outcomes of this child. Early post-operative complications, most common or most rare as I already mentioned with the coronary ischemia or infarction. What is the mechanism? If there is any technical error in transfer, there can be kinking, stretching of the coronaries or torsion on the transfer coronary button can be there. This is most weird and listed fatal complications. Usually earliest presence in ST changes or arrhythmias in the event, or slowly there can be low cardiac output syndrome. Low cardiac output as a long operative time, bypass time with poor myocardial protection can lead to low cardiac output, or there can be contributed to coronaries inadequate, improper coronary transfer techniques also, or can be due to residual VSD or residual outflow tract obstruction. Supravalvular pulmonary or branch PA stenosis, usually seen, we can watch it during the after rewarming or after during a clamp removal, and any tension in the anastomosis is there, or kinking or stretching of the pulmonary vessels over the aorta or branch PAs, we should to look for when particularly there is a mismatch to watch that. As mentioned, arrhythmia can be due to coronary event or need to have edema, or to during mobilization there is injury or maybe injury to sinus node or connection system can be there due to VSD closure also. Then as extensive suturing is there with prolonged bypass time, we should also for expectation bleeding here that means to address with what medical or well, surgical consideration. And diaphragmatic paralysis, though it is less common nowadays, but can be chance during mobilization of pancreas. There can be injury to pancreas. So, recognition and management of coronary event. So, clinically, what can be the consequences of coronary event? There can be coronary signs of coronary ischemia. In fact, will be ventricular ectopes are there, or maybe fibrillation in ST segment changes can be there, or challenge going into low cardiac output syndrome, or there will be difficulty winning from the bypass. So, immediately intraoperatively, we can directly visualize the coronary territory where there is any change. Air trapping is there, or color changes are there, dusky myocardium is there, and we can also do transesophageal echo or electrical and Doppler to look for coronary flow, or impossible, usually visible in the cardiac echo. Then corrective, so interval correction may be required to revise the coronary anastomosis to avoid the kinking, to relieve the kinking or maybe torsion, and we can use trap doors or make in cases where stretching or improper implantation, we need to revise it. Post-operative, there should be high index of suspicion, particularly when the anomalous origin of coronaries are there. We should look for serial ECG on monitor, or maybe check for troponin levels regularly, or on echocardiography can look for any almost abnormalities, which can help to take the decision whether to revise or optimize the child post-operative. In extreme cases, when there is rigorous TMV with borderline LV thicknesses there, in cases when there is difficulty in winning from bypass, particularly two-stage operation, we can use a myocardial ECMO support may be required to recover the myocardium from the damage. Long-term outcomes. With improved surgical techniques over the last 4 decades and meters management, or with a new advancement in the technologies, long-term survival for ASO excellent is 95 to 97% survival in case of high volume or extreme centers. Trained surgeons are there, with long-term survival at 25 years is around 90%. Many large single and multi-central cohorts is found. Freedom from renal intervention is around 75% from any surgical or catheter intervention. And many of these survivors of ASO are now grown up in the 3rd or 4th decade of the life, with great cohort is forming after this survival from these survivors. Late mortality is dominated mainly due to coronary event, or cardiac leading to cardiac death, or may long-term due to heart failure. Outcomes are usually volume and center dependent, particularly in cases when there is complex coronary patterns are operated or associated lesions, the tossing wing or associated alveolar obstruction or arch anomalies are. And surveillance for the new aortic root. As we saw, pulmonary artery is not made for. The main factor is that pulmonary artery is not made for the systemic circulation. Now, post surgery, this native aortic root, new aortic root, that is native pulmonary root, is a initiating path for the systemic circulation, and it is exposed to the systemic pressure for the first time. And in cases of VSC, there can be a mismatch in the size also there. There may be progress dilated proximal aortic root will proximal pulmonary arteries that will lead to new aortic root will be larger than the distal pulmonary arteries. That leads to so what are the that leads to over the time dilatation and of the new aortic root lead to over the time aortic regurgitation. So these factors for these are any pre-existing size mismatch between this great vessel or any pulmonary artery, bending work done, then we augmented with the pericardial patch, or any associated condition like tossing and oil. So it is usually over the time in only 5-10 years this regurgitation develops, but usually it is mild and slowly progressive in nature. But it occasionally requires wire sparing root surgery or replacement, particularly in the 2nd and 3rd decade of the life. So regular echo surveillance is required for when measuring your diameter and your wall competency. It's a lifelong surveillance in these cases. Branch pulmonary artery stenosis and coronary surveillance. The most common intervention for post-arterial septic operation is the branch pulmonary artery stenosis leading to supravalvular pulmonary stenosis. There can be due to leg contaminant during the GMAT, due to leg contaminant there may be excessive stretching of the branch pulmonary vessels, or maybe PA bending site with them, or any anastomosis because of mismatch or under tension. Usually present with a ejection systolic murmur in the pulmonary area, or maybe even echocardiography, there is RVH is there, or maybe reduced exercise tolerance. Can be managed with balloon angioplasty or staging most of the cases, but if it is not possible with that, we require surgical intervention with augmentation of pulmonary artery, or maybe in cases of RVT muscle resection in cases of subvalvular and stenosis. And coronary artery surveillance. The stenosis is usually uncommon, but still unrecognized and can present as a silent ischemia. Surveillance strategy is individualized. Baseline echo assessment usually done, or maybe additional CT or MI may be required for further imaging if any symptoms or any signs or any anomalous coronary like single ostea or internal coronaries are there. Then it's a regular surveillance with CT or MRI. CT is preferred but it exposes to radiation also, and usually enough to guide us whether any ostea or proximal course anomalies are they have narrowing or kinking there. So lifelong surveillance framework is diagnose the child infancy or neonate period and operated for NSO. We usually clinical review with follow-up of 6 to 12 month interval, and assess look for any associated baseline assessment at the first year, the root, aortic roots, diameter, valve, competency, branch space, stenosis, and ventricular function. In adolescents, we do additional exercise testing or periodic ECG Holter monitoring is required in cases of arrhythmias or state changes are there. It is usually lifelong cardiology follow-up with them. And after around 18 years, we transition them to adult congenital heart disease services with a formal handover from the adolescents. And in adulthood, imaging with echo is routine in that, but CT MRI as per guides. As per routine, CT MRI is done as per requirement of which guided by root size or valve competency and any coronary anatomy in echocardiography. Pregnancy planning usually needs to discuss with when there is relevant high risk factors are there, like regurgitation or coronary anatomies. So in every stage, low threshold for further imaging is required if a patient develops any symptoms, murmur or change in the ECG. Neurodevelopment outcomes. Children with TG are already exposed with altered fetal cerebral oxygen delivery. They are already cyanosis from birth and already in way of during fetal life they are also exposed to hypoxia. So they are already at the risk, inherent risk of neurodevelopmental differences. And with perioperative contribution can be due to prolonged bypass time in cases of heart super may require circulatory arrest, or there can be post-operative event with cardiac output syndrome, or still can run to neurological consequences. So formal development, formal neurological follow programs are recommended in cases of high risk congenital heart disease like operated TGS spectrum. Usually most of the children achieve good functional status and quality of life, but subtle deficits in executive or maybe motor skills are still common than in the normal population. Pregnancy planning and adult with congenital heart disease consideration is that most women usually do well after arterial operation and tolerate the pregnancy well. with their counseling and risk stratification. If any echo findings are there of long-term consequences, we need to address. The particulars are the new aortic root size and function, any residual RUT or branch pulmonary artery stenosis there, or any coronary narrowing in the ostia or the branch phase is found on the CT by MRI. So SEC 2025 guidelines for adult congenital heart disease provides a framework for this lifelong adult congenital heart disease care, including the reproductive counseling. So there is structural transition from pediatric to adult congenital service is essential, and that for that regular follow-up is required. So in those two follow-up, there is still risk in these complaints. Few controversies about the steps and the consequences follow-up. Whether to each leg community or no community. Advantages of leg community is to it provides a direct connection of transfer to the neo-pulmonary route. But whether when there is side-by-side vessels or coronary anatomy is proprietary for this leg community, whether we should use it or not. Most of the cases we can still do leg community whenever, and usually prefer on most of the cases. In coronary surveillance, there is no initial consensus about which modality to be used or at which interval, but CT is preferred to exposes to radiation or contrast. And rapid versus staged LV training in cases of later index of DVJ. So longer interval, 2 stage has a smoother recovery as per the reported literature. Has a better smoother recovery early post-operative than the rapid 2 stage. And what is the optimal LV mass or geometry or size, LV size or shape which will guide to those arterial switch or not is still debatable. And varies from the center to center. So population-based cohorts continue to confirm that there is excellent 20-year survival, around 90% of non-operated cases, but still there is a late mortality gap then comparing to the normal general population is there. And scoping reviews highlight that the long-term coronary complications are still unrecognized and inconsistent. He reported across the follow-up studies. Systemic reviews for new aortic root confirm that there is still gradually and progressive aortic root dilates, but very rarely, around 20-25% may be required intervention over the time for around 25 years. For imaging study, that cardiac CT angiography is still the complementary to echo, and because it is easily accessible and surveillance tool alongside with the echo. And adult ASO population is now developing in numbers, reaching into the 3rd and 4th decade of life, and we need to reset their long-term counseling. So putting all this together, the care pathway, antenatal or any antenatal or immediate postnatal suspicion is there, confirm with the diagnosis, define the coronary patterns, associated lesions, stabilize in cases of extreme cyanosis with prostaglandin and voluntary septicectomy with restrictive hypoxemic physiology. Switch usually done within first 2 to 3 weeks of life, or it may be staged when presenting late. Structured early post-operative surveillance is required for any coronary events, any aortic root or any residual lesions, and lifelong follow-up for new aortic root and branch pulmonary artery stenosis, coronary artery status and neurodevelopmental, and then transition to the adult congenital heart disease. So the take-home message for is that DTG is a ventricular arterial disorder without atrioventricular concordance. Survival depends on, without surgery depends on the mixing, not on a recurring the whole. Coronary anatomy is the single most determinant of surgical risks, and not just associated lesion like VSD or arch. Usually, arterial switch operation is the standard of the care for this anomaly. It provides an anatomical correction because LV is ejecting into the systemic circulation and preventing the RV as a systemic ventricle failure. Timing is the most important for this surgery. Almost everything it depends on the timing. Neonatal ASO with interceptor within 2 to 3 weeks, and was stage LV returning if presenting less. And in cases of VSD or any associated lesion, we can with headache expectation, we can wait for 4 to 6 weeks. Post-operative follow-up is lifelong. I can take particular interest in the aortic root dilatation, transcoronary artery stenosis, or a neck coronary status is required with structured surveillance programs till adulthood and beyond. These are my key references. Thank you for your kind consideration.